So why are we doing this series? First of all, some of you may be on the IOM continuum, and this will help you realize how you can fit dry needling into all the other manual therapy, exercise therapy that you use. If you're wondering whether you should include dry needling as an extra tool in your toolbox, this should help you decide whether or not maybe it's something you want to add. And for those dry needling practitioners who may want some help with integrating it into their practice, I'm hoping that this series will help you with that. So what will we cover in the series? We'll have case studies of familiar problems. It'll give you some ideas about considerations you should use in your examination. When is it appropriate to include dry needling in your plan of care? How do you make that differential diagnosis? What things within your examination will point to the fact that perhaps there's a myofascial element to their pain generators? We'll include recent research studies to support the approach of using dry needling in your practice. And we'll have some illustrations, video illustrations of the actual needling. And at the end of the presentation, I will sign off with the rest and take questions from our live people joining us. So our first case study is a chronic right epicondylitis. It's a 51-year-old man, Greg, who has a history of having worked in a factory doing heavy repetitive work with his arms. But back in 2000, having worked most of his life in this line of work, he developed terrible back pain and ended up with a fusion. He had a rotator cuff repair after long-term shoulder problems on the same side, on the right side, in 2011. And he's been told by his doctors that he has arthritis in his neck, and indeed he complains of achy stiffness, soreness occasionally. He's had 2 years of severe right elbow pain. And for this elbow pain, the doctors have done multiple injections, some of which helped a bit, but it always came back. And he's had several courses of physical therapy with a recurrence each time. The therapy helped. It usually calmed it down. He felt he was better, but it would always recur. And he does deny having done anything which has kind of perpetuated this. As I say, he's retired. The specialists have now implied that the next stop after this, if this course of therapy doesn't work, is surgery. So what were our findings? We did a cervical spine screening, and we found that he did indeed have decreased active and passive range of motion. And on segmental mobility tests, he was very hypomobile at C4, C5, C6 levels. And there was tenderness with that testing, and we noted increased tone in that mid-cervical paraspinal area. On observation, he had wasting of the right scapular muscles compared to the left, and definitely decreased strength of the right abduction and external rotation in the shoulder. When we looked at his abduction elevation for his shoulder screen, we saw that he lost scapular stabilization, especially with descending from abduction elevation, only on the right side compared to the left. And on our part of our palpation exam, we did note that there were taut painful bands in the infraspinatus, but there was no referral when we compressed them, so they didn't appear to be very active. When we looked at our elbow, there was 5-degree loss of elbow extension with a springy end feel. He had pain and weakness on resisted wrist extension, which was what we would expect to find with a chronic epicondylitis. And on palpation, he had exquisite pain at the lateral epicondyle and painful taut bands found in brachioradialis, brachialis, and extensor carpi longus, radialis longus. So what are our treatment considerations here? So he's had other courses of physical therapy, and they've all helped, but his pain has always recurred. And this particular patient was referred by his primary physical therapist to me to try dry needling. So I tried to think globally. How can we approach this in a different way and get better results? Could his neck and shoulder be contributing to this? We are going to look at the theories of satellites, satellite trigger points, agonists, antagonists when we think of a myofascial pain syndrome possible cause. Could the muscle activation patterns in his shoulders, which in his right shoulder, which seems to be altered, be feeding into this problem? And could he have a neuropathy? And how can dry needling approach any of these problems? So let's start with our first treatment consideration, the local area, looking at the theories of satellites, antagonists, agonists in a possible myofascial pain syndrome approach. Obviously, in the past treatment courses that he's had, the therapists have approached the local area with iontophoresis. They've done cross-friction massage, and they've done anti-inflammatory modalities, and they've given him some help. But as we said, it recurred. So maybe it could be a trigger point approach. So what are satellite trigger points? In his case, we know that he has a history of this rotator cuff problem, and satellite trigger points really are trigger points which form in the referral area of either primary trigger points or even a true radiculopathy. And this could have been consideration, considering he had a rotator cuff repair. He may have developed satellite trigger points in the elbow area. And if we look at this referral area here of supraspinatus, you see that those trigger points in supraspinatus refer an area in the side of the arm and at the very strong area in the lateral epicondyle. So it's quite possible that he could have developed quite a major latent or satellite trigger point in that area, which didn't necessarily clear when he had his rotator cuff repair. So this is a possibility, and we do know now that we are finding definite trigger points throughout the agonists of this area of the forearm extensors. I'm going to show you an example of needling of the brachioradialis. And when you're needling brachioradialis, you look at, you're really going to be certain that you have your surface anatomy very clear, and we definitely teach that surface anatomy in your courses. And IOM have a fabulous surface anatomy app, which is out right now. You might want to consider. But as we're looking for that, we note that the crease of the elbow is usually about the level on the brachioradialis, which you'll find your trigger point. You get a nice pincer grip, which is safe. You're staying away from the cubital fossa, which you've identified. And you're going to put a needle into that pincer grip. You've lifted it away, so you're not going to catch any of the ulnar nerve or the vessels in the cubital fossa. And you needle in this area. So let's go back to treatment considerations. So we've addressed the local area. What else can we consider? Could that be a problem coming from his shoulder, or could that be feeding into that problem? So what would the evidence be to think that muscle activation problems could actually lead to distal trigger points in his elbow or pain in his elbow? And there have been some great studies done on this. In 2011, G. and Arndt Nielsen did a study on looking at the effect of latent trigger points on movement. And this study really basically concluded that trigger points, myofascial trigger points, were definitely associated with reduced efficiency of reciprocal inhibition. And they thought that that would contribute to things that they saw, which was delayed and incomplete muscle relaxation after exercise, and disordered fine movement control. This is important when you're looking at the muscle activation patterns, and an unbalanced muscle activation. And they concluded that elimination of these latent trigger points being trigger points that don't necessarily cause the patient's pain, but they're changing the muscle strength and flexibility. And they felt that if you treated them or eliminated them, it could prevent them from becoming active, and it may improve their motor function. Another study done by Lucas was interesting. This was using surface EMG and looking at scapular positioning during loading of the shoulder as the patient moved through movement, with both a control group who did not have any latent trigger points found, and then a latent trigger point group. And they did find that in the trigger point group, that it altered the muscle activation pattern during scapular plane elevation, and they felt that that could possibly predispose people to overuse conditions, including impingement, rotator cuff pathology, which he had, and myofascial pain. Another good study, so that really gives us an idea that perhaps latent trigger points are indeed a possibility in considering his persisting pain. So what about another approach? Could it be a neuropathy, and how can dry needling approach this? So we look at Dr. Chan Gunn's work when we think about neuropathy and trigger points, and he developed an entire system of trigger point treatment which he called intramuscular stimulation. And this was back in the 70s and 80s. He came up with his theories about myofascial pain. And he worked on the premise, and still does, that trigger points are caused by a spinal problem, a spondylosis, which is affecting the nerve conduction, and also that it affects reflexly, causes compression at the segmental level, because you have development of segmental trigger points at the spine, which can then affect the dermatome further down. So do we have any good evidence of this? So even since then, there have been quite a few people doing research which do hold up those theories of neuropathy. And in 2009, Fernando de las Piñas found that he was looking at a clinical perspective. So he really looked at the different studies that had come out on this subject, and he found that the studies did show that an increased tension in taut bands may cause an abnormal displacement of facets, which cause compression. And also possibly it works the other way. Perhaps abnormal sensory input from the dysfunctional facets may reflexly activate the trigger points. So keeping this in mind, perhaps that local compression at the spinal level could be contributing to the nerve conduction and the formation of trigger points further down. In a study of 60 subjects with lumbar disc prolapse, Samuel and his colleagues found that there was a significant association between disc disease and the presence of trigger points in the muscles that were innervated by the corresponding segmental level. So it would then make sense that if this happens in the lumbar area, it may indeed happen at the cervical spine level, and if this patient of ours has some joint pathology at that spinal level, it may again affect that dermatomal level. And another study that was interesting done looking at the forearm muscles in patients with chronic unilateral epicondylalgia. They did a double-blind study where they had people that had chronic epicondylalgia and others that had no epicondylalgia, and they found that in the group that had the chronic epicondylalgia, that they formed latent trigger points on the other unaffected side. And they felt that as a result of this finding, perhaps that presence of bilateral findings could be a central sensitization, and that may explain why we do see patients with bilateral problems like this. Another study on looking at trigger points, paraspinal dry needling added to treatment in patients with chronic severe upper trapezius trigger points. and this was in the elderly, they found that that in the group of patients that had both trigger points needling in the trapezius and the paraspinal, compared to ones who only had trapezius needling, that group of patients had more improved range of motion, less pain, and even less depression. So that also kind of adds to that, our feeling that there's something to that. And I'm going to show you now a video on needling the paraspinal area. Sorry, let's do that again. Here we have our surface anatomy. We've counted down our spinous processes, and we do not, here we have our C7, and we've felt C2 as our first, and now we're going to do some needling between C4, 5 in this case. You'll find that your knowledge of 3D anatomy is so very important. Your surface anatomy is important, but your 3D anatomy is so important in these cases. And we are so blessed to be able to offer some courses in specific venues, which also include cadaver anatomy, which we go into our cadaver lab. Here we're looking at a 40-millimeter needle going down. We have to punch through the fascia into trapezius, into the spleniae, down into semispinalis, and finally into the multifidus area. And the idea here would be to release that compression that you're getting on the C5 level, which could affect your nerve root. And in this case, we would want to be needling bilaterally to get that release of compression. We haven't yet addressed the actual sore spot. And so is there anything in dry needling that we could offer that might give us some effect very, very locally? And the needling solution could be periosteal pecking. He's had multiple injections. He's had all our other kind of modalities that we've been able to offer, but he hasn't had something like periosteal pecking. And is there any evidence to support doing taking a needle and periosteal pecking on that teno-periosteal junction? Well, indeed there is. Back in 1983, Bratberg looked at whether or not just periosteal pecking was as useful as steroid infiltration, and in his little study, he said that it was actually more beneficial. It had better lasting effects. Another study that looked at comparing just intramuscular stimulation, which is needling into the muscle belly, and periosteal acupuncture on its own could have similar effects. And Hansen found that there was no difference between the intramuscular stimulation, the intramuscular needling, and the periosteal pecking. And an interesting study which has been done on autologous blood injection for tennis elbow, which was ultrasound guided, was a study in which they went in first of all and did pecking, dry needling in the area of the tennis elbow pain, and then they took an injection and they injected autologous blood into the area, and they felt that that was very effective and more effective than the steroid injections. So this idea of blood is interesting because we feel that when we're doing just straight dry needling, we obviously will cause small amounts of bleeding in the local area. And if indeed that bleeding brings in all our platelet-derived growth factors, which will help the connective tissue to basically remodel in such a way, and that's what they found with this guide. When they looked at the tissue in the ultrasound after the autologous blood injections, they found that there was a true remodeling of the tendon in the tennis elbows. So what is our local picture here? our thing that what we must do first is we must address the patient's pain. We have to get buy-in from the patient. He's been through a lot, and if we just went right away and to his neck and said, I'm going to do treatment on your neck, he probably wouldn't really believe that we could help him. So, but when we address those forearm muscles, we must remember that they can be the victims. Okay, so the victims of something going on elsewhere. The most obvious active trigger points to treat first are the ones that also are weakest, and those would be the extensor carpi radialis longus and brachioradialis. And we must try to help out the joint. Brachialis usually limits elbow extension, and it can become overworked as an agonist for the weakened brachioradialis, so we should do something about that. And then remember that the tenoperiosteal junction may need that remodeling. So let me tell you about Greg's course of treatment. The first day that I saw him, I did dry needling of brachioradialis, extensor carpi radialis longus, and brachialis, 3 needles. He had explosive twitches of the extensor carpi and the brachioradialis, and he had 2 really good twitches in the brachialis. And following the needles, we had full elbow extension with a nice hard end feel, so that definitely the needling had released that. And his resisted wrist extension test was less painful. We saw him when we saw him again for needling 1 week after. He said he had been pain-free. He'd been sore for about a day, and then he'd been pain-free for an entire week. So this was great. And he was seen again on day 4 to start an exercise regime, and he was exercised in his pain-free range with some slow eccentric training also. So he was seen again on day 8 for a second treatment of dry needling, and in this situation we did more dry needling of some residual trigger points in brachioradialis. It was the only thing that we found was one of the higher trigger points, and then we did periosteal pecking in this instance to a small area of tenderness in the tenoperiosteal junction. And this area of tenderness was considerably small, having released the tension from the brachioradialis and others. So after this needling, we got 2 more good twitches at brachioradialis, and he had exquisite pain with the periosteal pecking, but he was pain-free again for 1 week. But he later got a recurrence of pain at the common extensor tendon, but no real pain with his exercise program, and he was having exercise in between there. On the 3rd day for dry needling, we did approach the other more distal areas, and I did dry needling of the C5 deep paraspinals, both left and right, and I did dry needling of infraspinatus, once more of brachioradialis, and the tenoperiosteal pecking as before. We had an improved range of motion immediately with C-spine rotation, and he had a deep ache with his with the dry needling, but only a mild ache with infraspinatus needling. So we still got some twitches of brachioradialis and much less pain with periosteal pecking. It was hard to find a local tender spot in the area of his tendinous junction. So how does this treatment continue? Well, it does continue because he's still an active patient. He's gone off on a vacation, but my plans for the next treatment would be to be more global in these final treatments, using joint mobilizations in the C-spine, adding shoulder stabilizations, and very, very much functional strengthening. So to conclude, why do we want to do dry needling? Well, as you see, the results were fast. We rendered him pain-free after 1 day of a little bit of soreness after the treatment. The other treatments had failed, so that's a good reason to try it. And it really did enable us to approach more areas within 1 treatment session, as you saw in that last section of dry needling. We could approach the compression at his C-spine. We could approach some of the problems with his muscle activation by getting rid of the latents and the local area. And then we know from what I've just told you that the science will back up our choice of treatment. So there is good science behind our treatment. At this point, I'll tell you a little bit more about our courses. We do have a certification program where you take your first course. The courses are now hybrid as of 2016. With the help of IOM, we have developed some wonderful courses. You get to sit at home and learn the theory well, and you come to the 2-day practical intensive with everyone being on the same page, ready to do your needling. And our first level is all the common, safest areas to needle. And then the second level, which is also a hybrid course with more good theory, in the online course, followed by the 2-day intensive, will cover all the other areas of small muscles in the arm, hand, foot, leg, and the more dangerous areas of the thorax and chest. And it finishes with with you submitting six of your case studies and doing a written exam for your final certification. So that's our program. And I'm going to close now. Please go onto the IOM website to find our courses. We hope to find you at some of them. It would be nice to meet you. And I'm going to close and take questions.